So let me take up the next very important topic, that is diabetes mellitus. Now diabetes mellitus is the clinical condition which is characterized by hyperglycemia. Right? It is a clinical condition which is characterized by hyperglycemia. Now mainly this diabetes mellitus, it is of two forms. Right? There are many forms of diabetes. Mainly we have two forms. One is type 1 diabetes mellitus and the other one is type 2 diabetes mellitus. Right. So if you take type 1 diabetes mellitus, this is mainly because of autoimmune destruction of the beta cells. Right? Type 1 diabetes mellitus is mainly because of autoimmune destruction of the beta cells, and thereby insulin production or the insulin levels, they are completely reduced. Whereas you take type 2 diabetes mellitus. Type 2 diabetes mellitus is mainly because of insulin resistance. Right? Is mainly because of the insulin resistance. If you take the target organs for the insulin or the target sites for the insulin, remember the target sites for the insulin is the skeletal muscle, liver and adipose tissue. So on these particular sites the insulin receptors are present and the insulin will act on these the target organs. So there at the point of the target organs, they will have insulin resistance in these patients with the type 2 diabetes mellitus, and thereby the glucose will not enter into the cells. So that will be characterized by hyperglycemia. But here as such, if you take the insulin levels, they are very much increased in these patients with the type 2 diabetes mellitus. So these are mainly the two forms of diabetes mellitus. Now let me discuss in detail about the type 1 diabetes mellitus and as well as type 2 diabetes mellitus and as well as the other forms of diabetes mellitus, and what will be the clinical features, complications, and how do you treat this particular diabetes mellitus. Right? So first let me start the discussion with the type 1 diabetes mellitus. If you take type 1 diabetes mellitus, this form of diabetes, it is an immune mediated disease. That is, it is an autoimmune disease. Right? It is an autoimmune disease. So the antibodies, they are formed against the beta cells and they will cause the beta cell destruction. Right? They will cause the beta cell destruction. Now, so if you take this the antibodies, what are the name of these antibodies? They are the GAD antibodies, that is glutamic acid decarboxylase antibodies, or they are called as islet cell antibodies. Right? They are called as islet cell antibodies. So these antibodies, they are produced against the beta cells and they will cause the destruction of this particular beta cells. In this particular immune mediated disorder of type 1 diabetes mellitus, it is mainly mediated by T lymphocytes. Right? Mainly it is mediated by T lymphocytes. And the other important thing is the age at which you see the type 1 diabetes mellitus, it is less than 20 years. Right? The age at which you see is less than 20 years, and it will progress along with the age of the individual. Next, now if you take the clinical features in these individuals with type 1 diabetes mellitus, they will have classical clinical features, that is they will have polyuria, polydipsia and as well as polyphagia. So polyuria, polydipsia, polyphagia, these are the very important clinical features in these patients with the type 1 diabetes mellitus. Now, if you take the onset of these clinical features, the onset is abrupt in onset. Remember, they will not have gradual onset of the clinical features, they will have abrupt onset of the clinical features. That is, when nearly around 90% of the beta cells, right, nearly around when 90% of the beta cells, once they are destroyed, then there will be absolute insulin deficiency, due to which they will develop this particular polyuria, polydipsia or polyphagia. Alright. So if you take the clinical features, they are abrupt in onset. Now, so they will have what? They will have absolute insulin deficiency. Why? The beta cells are completely destroyed. Now, you take in type 1 diabetes mellitus. Because of absolute insulin deficiency, remember, because of absolute insulin deficiency, they develop an acute complication. Right? They develop an acute complication which is called as diabetic ketoacidosis. So, diabetic ketoacidosis is very important acute complication in these patients with the type 1 diabetes mellitus. Next, if you take the genetics, right? If you take the genetics in these patients with the type 1 diabetes mellitus, remember which group of individuals they develop this type 1 diabetes mellitus is those group of individuals who have HLA-DR3. Right? Those group of individuals who have human leukocyte antigen DR3, they are the one who are associated with type 1 diabetes mellitus. This HLA-DR3, that is human leukocyte antigen DR3, that will code for class 2 MHC locus. Right? That will code for class 2 MHC locus. So these are the group of individuals who will develop type 1 diabetes mellitus. Next, if you take the inheritance, remember only 6% of patients will have inheritance in the first degree or first order relatives. Right? Only 6% of patients, they will have inheritance in the first order relatives. Right? So let me shortly revise. So type 1 diabetes mellitus, it's an immune mediated disorder which is mediated by T lymphocytes. The antibodies are being formed against the beta cells and they will destroy the beta cells. They will have beta cell destruction. And the antibodies are mainly the GAD antibodies and as well as the islet cell antibodies. The age at which you will see type 1 diabetes mellitus is less than 20 years. And they will have the classical clinical features, that is polyuria, polydipsia and as well as polyphagia. And these clinical features, the onset, it is abrupt in onset. And when does these clinical features develop? When nearly around 90% of the beta cells, once they are destroyed, there will be development of the clinical features, and they are characterized by the presence of absolute insulin deficiency. And because of absolute insulin deficiency, they will develop an acute complication which is called as diabetic ketoacidosis. And if you take the genetics, those patients who are having HLA-DR3 will develop this type 1 diabetes mellitus, and this HLA-DR3, it will code for class 2 MHC locus. And if you take the inheritance, it is only 6% of children with first order relatives with type 1 diabetes mellitus will develop this particular disease. And next, now if you take the another important point, the complications already we have discussed, that is diabetic ketoacidosis. Now you see the pathogenesis, that is autoimmunity. Right? Why there will be development of the antibodies? Because those individuals who are having HLA-DR3 will develop these antibodies. Now apart from that, you take in pathogenesis. Right? Apart from that, if you see in the pathogenesis, remember there are certain environmental factors. Right? There are certain environmental factors which play an important role in the development of type 1 diabetes mellitus. Now what are those environmental factors? Remember, these environmental factors, they will trigger the autoimmunity. And what are those environmental factors? It is mainly the viral infections. It is mainly the viral infections. Now you see, what are those viruses or what are those viral infections which will cause type 1 diabetes mellitus? Remember, viruses as such, they will not attack the beta cells. Whenever there is viral infection, our immune system will produce the antibodies against the viruses. right? Our immune system will produce antibodies against this viral infection. The antibodies whichever are being produced against the viruses, they will destroy the beta cells. Right? They will destroy the beta cells. This is what is called as the autoimmunity. Now, what are those viruses? They include mumps. Right? These include measles. Right? They include Coxsackie virus, cytomegalovirus, rubella, and Epstein-Barr virus. So these are the viruses which are associated for triggering the autoimmunity. That is mumps, measles, Coxsackie virus, cytomegalovirus, rubella, and as well as Epstein-Barr virus. A very important point that need to be remembered, the viruses, they don't attack the beta cells. The antibodies which are formed against the viruses, they will destroy the beta cells, resulting in type 1 diabetes mellitus and causing absolute insulin deficiency. Now, so these are some of the important features about type 1 diabetes mellitus. Now, so in order to discuss about the type 2 diabetes mellitus, what I will do is, I will compare the type 2 diabetes mellitus with type 1 diabetes mellitus. Now, first and foremost is the age. So if you take the age of the patient with type 1 diabetes mellitus, the age is around less than 20 years. And if you take the age of the patient of type 2 diabetes mellitus, it is more than 30 years. Right? The age group at which you get type 2 is more than 30 years. Next, if you take the weight of the individual, you take type 1 diabetes mellitus, they will be of normal weight. Right? They will be of normal weight. Whereas you take type 2 diabetes mellitus, these individuals, they are obese. Right? These individuals, they are obese. Next, you take the genetics. Right? Next, you take the genetics. Remember, type 1 diabetes mellitus, the inheritance in the first order relatives is only 6%. Whereas in type 2 diabetes mellitus, the inheritance in the first order relatives is nearly around 70 to 80%. Right? The inheritance in the first order relatives in type 2 diabetes mellitus is 70 to 80%. Next, association with HLA. Right? Association with HLA. If you take the association with HLA, the type 1 diabetes mellitus, yes, they are associated with HLA, that is DR3 and as well as DR4. Whereas type 2 diabetes mellitus, there is no HLA association. Right? There is no HLA association. Next, if you take the pathogenesis, right? If you see the pathogenesis, type 1 diabetes mellitus, the pathogenesis is autoimmunity. Right? Pathogenesis is autoimmunity. That is, the antibodies are formed against the beta cells. Whereas type 2 diabetes mellitus, the pathogenesis is insulin resistance. Right? The pathogenesis is insulin resistance. Now, you take the islet cells. The islet cells in patients with type 1 diabetes mellitus, there is complete destruction. Right? The beta cells, they are completely destroyed in patients with type 1 diabetes mellitus. But whereas you take in type 2 diabetes mellitus, there is no destruction of the beta cells. Only in the late stages of type 2 diabetes mellitus, there is mild beta cell destruction. Right? In the late stages, there is mild beta cell destruction. Next, you take the insulin levels. Right? You take the insulin levels. In patients with type 1, the insulin levels, they are reduced. Whereas type 2 diabetes mellitus, the insulin levels, they are increased. But in late stages, whenever there is mild beta cell destruction, that is the point when the insulin levels may be reduced. Otherwise, the insulin levels are increased in patients with the type 2 diabetes mellitus. Next. Now, apart from this, let me tell you some of the other differences. You take the clinical features. In type 1 diabetes mellitus, they will have the classical clinical features, that is polyuria, polydipsia, and as well as polyphagia. Whereas, you take in patients with type 2 diabetes mellitus. In patients with type 2 diabetes mellitus, the clinical features is increased fatigue or weakness, right? Increased fatigue or weakness. There will be impaired wound healing, right? There will be impaired wound healing. There will be repeated infections, right? There will be repeated infections. So that is what we see in patients with the type 2 diabetes mellitus. Next, if you take the complications, right? If you take the acute complications, the acute complications in type 1 diabetes mellitus, it is diabetic ketoacidosis. Whereas in type 2 diabetes mellitus, it is hyperosmolar non-ketotic coma. Right, it is hyperosmolar non-ketotic coma. That is the acute complication in type 2 diabetes mellitus. And if you take the treatment, in type 1 diabetes mellitus, we give only insulin. In type 2 diabetes mellitus, we give oral hypoglycemic agents. And occasionally, even in patients with type 2 diabetes mellitus, they require insulin also. But mainstay of treatment in type 2 diabetes mellitus is the oral hypoglycemic agents. So these are some of the differences between type 1 and as well as type 2 diabetes mellitus. Now, after having discussed about the differences between type 1 and type 2, let me discuss what are the risk factors for the development of type 2 diabetes mellitus. Right? What are the risk factors for the development of type 2 diabetes mellitus? So if you take the risk factors for the development of type 2 diabetes mellitus, first and foremost, very important is obesity. Obesity is a very important risk factor for the development of type 2 diabetes mellitus. And that too, which obesity? Central obesity is a very important risk factor. So this particular central obesity, right, there will be presence of excess amount of intra-abdominal fat, right? There is presence of excess amount of intra-abdominal fat. That is a very important risk factor for the development of type 2 diabetes mellitus. Next, the other thing is birth weight. If the birth weight of the individual is more, there is a very high chance that in the later part of the life, there is a high chance of developing diabetes mellitus. And the third point is the lifestyle factors. Right? The third point is lifestyle factors. Remember, lifestyle factors like sedentary lifestyle, right? Like sedentary lifestyle, consumption of high fatty diet, inadequate exercise, heavy smoking. So remember, these are the lifestyle factors which can make an individual to develop this type 2 diabetes mellitus. And next thing is even the sleep duration. Remember, if the individual is having inadequate sleep, or if the individual is having a disturbed sleep, that is also a risk factor for the development of type 2 diabetes mellitus. Next, the other important risk factor is vitamin D deficiency. So, the several prospective observational studies have shown that vitamin D deficiency was associated with the development of type 2 diabetes mellitus. Alright, so these are the risk factors for the development of type 2 diabetes mellitus. Next, so the inheritance already I have discussed, that is the genetics. Next is, you take the lipid profile in these patients with the type 2 diabetes mellitus. I have discussed when I was discussing hypothyroidism that there are two endocrine disorders where you have the dyslipidemias. One is hypothyroidism and the other one is type 2 diabetes mellitus. So, in patients with type 2 diabetes mellitus, if you take the lipid profile, right, they will have what is called as dyslipidemias. Right, they will have what is called as dyslipidemias. Now, so what is that dyslipidemias you will have in these patients with the type 2 diabetes mellitus is, they will have increased triglycerides. Remember, this is the most important dyslipidemia what you see in patients with the type 2 diabetes mellitus. And apart from increased triglycerides, there is also decrease in HDL, increase in LDL, increase in VLDL, and also increase in the cholesterol levels. Right, increase in the cholesterol levels. So this is what is the lipid profile or the lipid abnormalities what we see in these patients with the type 2 diabetes mellitus. Alright, next, coming to the, so this is about the type 2 diabetes mellitus which is seen after the age group of 30 years. Next, now let me discuss some other forms of diabetes mellitus apart from type 1 and as well as type 2. Right, let me discuss some other forms of diabetes mellitus apart from type 1 and as well as type 2. So we have a form of diabetes mellitus which is called as MODY, that is maturity onset diabetes of young. Right, maturity onset diabetes of young. Now remember, this MODY, it is non-insulin dependent diabetes mellitus. Right, non-insulin dependent diabetes mellitus. And an important point you should remember is the age group at which you see this MODY is around 25 years. Right, the age group at which you see is around 25 years. These individuals, they will have normal BMI. That is, they are non-obese. Right, that is, they are non-obese. And why is this occurring due to? Remember, it is due to beta cell dysfunction. Remember, it is not beta cell destruction. It is due to beta cell dysfunction. So because of this particular beta cell dysfunction, there is impaired glucose absorption. Right? There is impaired glucose absorption. Right? Now you see here, in these individuals, they will have very strong genetic inheritance. Right, they will have very strong genetic inheritance. That means to consider MODY, minimum 2 generations should be diabetic. That is, father and as well as grandfather should be diabetic to consider the diagnosis of MODY. Right, so the inheritance, it is a very strong genetic inheritance. Alright, now if you see the treatment of these individuals, right, if you see the treatment of these individuals, the treatment is you have to give a low dose oral hypoglycemic agent, and very particularly what we give is sulfonylureas. Right, very particularly what we give is sulfonylureas. So these, when you give this low sulfonylureas, they will stimulate the beta cells and they will produce insulin. It is only beta cell dysfunction, it is not beta cell destruction. Alright, so these patients with MODY, they don't require insulin. Right, they don't require insulin. Right, And if you take this beta cell dysfunction, it is mainly because of gene mutation. Right? It is mainly because of the gene mutation. And what you have to remember, an important point is, this MODY, it is having an autosomal dominant type of transmission. Right? Autosomal dominant type of transmission. Now, we have totally various forms of MODY. Right? We have various forms of MODY, starting from MODY 1 to MODY 6. Right? So in each form of MODY, there is various gene mutation which we will discuss. Right? So summarizing the MODY is maturity onset diabetes of young. It's a non-insulin dependent type of diabetes mellitus. It is seen around the age group of 25 years. These individuals, they will have normal BMI. They are not obese individuals. And this MODY is mainly because of the beta cell dysfunction. Right? And because of this beta cell dysfunction, there is impaired glucose absorption. And this beta cell dysfunction, it is mainly due to gene mutation, and this MODY, they are having autosomal dominant type of transmission. And these patients with MODY, that is maturity onset diabetes of young, they will have a strong genetic inheritance. Right? That means minimum 2 generations should be diabetic. That is father and as well as grandfather. Both should be diabetic. And if you take the treatment in these patients with MODY, you have to give a low dose oral hypoglycemic agents, that is sulfonylureas, which will stimulate the beta cells to produce the insulin. And these patients, they don't require insulin as a part of the treatment. They just require a low dose oral hypoglycemic agents, that is mainly your sulfonylureas. In this MODY, it is of various forms, like that is MODY 1 to MODY 6. Now, let me discuss what are the gene mutations in these patients with the MODY. Right? What are the gene mutations in these patients with the MODY? Right? So, if you take this particular MODY, like what did we see? We have seen the various forms of MODY, starting from MODY 1, 2, 3, 4, 5 and as well as 6. Now, you take MODY 1. In MODY 1, the gene which is being mutated is hepatocyte nuclear factor 4. Right? It is the HNF4 alpha. Right? It is HNF4 alpha which will make the individual to land up in MODY 1. In MODY 2, the gene which is being mutated is the glucokinase gene. Right? The gene which is being mutated is the glucokinase gene. Whereas in MODY 3, it is HNF, right? It is HNF1 alpha. Now, you see here, among the various forms of MODY, MODY 3 is the more common form of MODY. Right? MODY 3 is the most common form of MODY, in which there is HNF1 alpha mutation, that is hepatocyte nuclear factor 1 alpha mutation. And you take you take MODY 4, the gene which is being mutated is insulin promoter factor 1. Right? Insulin promoter factor 1. So that is what you see in case of the MODY 4. You take MODY 5, it is HNF1 beta. Right? HNF1 beta mutation will cause the MODY 5. And MODY 6, you have the gene mutation, that is nuclear differentiating factor 1. Right? Nuclear differentiation factor 1. So these are all the various forms of MODY, and these are all the various genes which are being mutated. And among all the genes, which is the gene which is the most common form? MODY3 is the most common form, in which there is mutation of HNF1 alpha gene. So in MODY, what is the treatment you give? In MODY, we give what is called as a low dose oral hypoglycemic agents. Now, there are some other forms of diabetes mellitus as well. The other forms of diabetes mellitus is, we have what is called as type 1.5 diabetes mellitus. Now, what is this type 1.5 diabetes mellitus? This is LADA, right? This is LADA, that is latent autoimmune diabetes of adults, right? Latent autoimmune diabetes of adults. Now, what is this particular LADA is, right? What is this particular LADA is? Why it is called as 1.5 diabetes mellitus? Remember, they are having the features of type 1 and they are having the features of type 2. What is that? They are having autoimmune form or autoimmune pathogenesis, which is a feature of type 1. And it is seen in adults, that is a feature of type 2. So, they are having the features of both 1 and as well as 2. So, that is why it is called as 1.5 diabetes mellitus. So, here also there is an autoimmune destruction of the beta cells, but it is in adults, right? So, because there is an autoimmune destruction of the beta cells, the insulin levels will be reduced. So, in patients with type 1.5, the treatment what we give is insulin, right? The treatment what we give is insulin. So, that is what is your type 1.5 diabetes mellitus. Next you see, we have other form of diabetes mellitus, which is called as type 3 diabetes mellitus. Right? Type 3 diabetes mellitus. Type 3 diabetes mellitus, it is seen in patients with the Alzheimer's disease. Right? It is seen in patients with Alzheimer's disease. So, in these patients with the Alzheimer's disease, the neuronal cells, they are unable to act according to the insulin. So, here in type 3, the neuronal cells, they will have insulin resistance. Right? They will have insulin resistance. That is what is called as the type 3 diabetes mellitus, which is seen in Alzheimer's disease. Next, we have type 3C diabetes mellitus. This type 3C diabetes mellitus, it is seen in patients with chronic pancreatitis. Right? So, whatever might be the reason for the pancreatitis. So, in patients with chronic pancreatitis, remember, they will have what is called as type 3C type of diabetes mellitus. Next, we have another form of diabetes mellitus, which is called as gestational diabetes mellitus. Gestational diabetes mellitus is development of diabetes mellitus in pregnancy, is called as gestational diabetes mellitus. Alright, so these are all the various forms of diabetes mellitus. Now we will discuss the diagnosis of diabetes mellitus.